Good morning, Dr. Mukape. I'm Rogers Jaire, a fifth-year medical student from the University of Zambia. Today, I have a case to present from the wards at UTH. This is a 28-year-old G2P1 woman at 33 weeks gestation who presented with a severe headache, blurred vision, and upper abdominal pain. On examination, her blood pressure was 160/105 of a millimeter of mercury, and the urine dipstick showed 2+ protein. I suspect she has preeclampsia.
Alright, Rogers. Let's dig into this. Can you define preeclampsia for us here in the D-Block conference room?
Preeclampsia is when a pregnant woman develops high blood pressure and proteinuria after 20 weeks of gestation. The blood pressure is above 160/100, and there is protein in the urine.
Rogers, if we waited for 160/100 to diagnose preeclampsia, we'd have women having strokes left and right. The cutoff is 140/90, not 160/100. Also, just any protein in the urine? Are we diagnosing preeclampsia on a whim? You need proteinuria of greater than or equal to 300 mg in 24 hours, or a protein/creatinine ratio of greater than or equal to 0.3.
Ah, I see. So, abnormal placentation leads to increased pressure, which damages various organs like the brain, heart, and kidneys.
Rogers, you're making preeclampsia sound like an organ war zone. It's not just random organ damage. The underlying issue is endothelial dysfunction caused by abnormal placentation, leading to widespread vasoconstriction and increased vascular permeability. That's what causes the hypertension and end-organ damage.
Got it. So, to manage her, I would probably monitor her for a few weeks and induce labor when things are more stable.
A few weeks? At UTH, Rogers, we don't let things escalate to a crisis. If she has severe preeclampsia, waiting isn't an option. You need to start antihypertensives, give magnesium sulfate to prevent seizures, and steroids for fetal lung maturity. The decision to deliver comes sooner rather than later based on the severity, not in a few weeks.
Okay. I would start hydralazine for blood pressure control.
Rogers, hydralazine is still around, but in 2024 we have better choices. Labetalol or nifedipine would be the go-to drugs here. Hydralazine isn't as predictable and isn't first line anymore.
Right, labetalol or nifedipine. And I'll monitor her for magnesium toxicity by checking her reflexes and maybe her temperature.
Her temperature? Rogers, are you checking if magnesium sulfate causes fever? You need to monitor deep tendon reflexes, respiratory rate, and urine output to avoid respiratory depression. If you're unsure, check the serum magnesium level, not the temperature.
I understand now, Dr. Mukape. I would also keep an eye out for HELLP syndrome, which is characterized by high blood pressure and low platelets.
Close, but no cigar, Rogers. HELP stands for hemolysis, elevated liver enzymes, and low platelets. Hypertension is usually present, but it's not part of the acronym. You're getting there, but let the acronym do its own job.
Thanks for the corrections, Dr. Mukape. I will definitely brush up on the details.
You're on the right track, Rogers. Mistakes are part of the learning process, and you're doing fine. Just make sure next time you read on the topic before presenting.